This conference will now be recorded.
Hello, good morning, everyone. Am I audible?
Yes, sir.
Huh?
Yes, sir.
Yes, sir.
Okay. So today's topic is the acute bacterial meningitis, or also known as pyogenic meningitis. Previously, this topic is completed for you or not yet completed? Hello, CR.
No, sir.
Okay, fine. So, if you see, the cut section of the head, there will be skin, periosteum, that is covering of bone proper, dura matter, followed by arachnoid matter, pia matter. So all these are called meninges. Dura matter, arachnoid matter, pia matter, or meningeal. So if you see, meninges will surround the brain tissue. This is white color one is the meninges, so that it is in continuation with the spine, skull and spinal cord. It's a normal anatomy of brain and spinal cord. Actually, what happens here in meningitis, the inflammation of this meninges here will lead to infection of the brain tissue proper also, and it will spread down to spinal cord as well. Okay. Acute bacterial meningitis in children, we will follow in this pattern: definition, etiology, predisposing factors, pathogenesis, symptoms and signs, diagnosis, differential diagnosis, complications, prognosis, treatment and follow-up. Okay. So if you take the definition of meningitis, it is an acute inflammation of meninges that everyone knows. Acute inflammation of the meninges, which are the protective membranes covering the brain and spinal cord, caused by bacterial or pyogenic organisms. This should be there. The causative agents are bacteria or pyogenic organisms. Okay. So if you take the etiological agents based on age, neonatal meningitis is a different entity compared to adults, because compared to older children, because the etiological agents will change in the neonatal period. Age less than 1 month, the most common bacteria are gram-negative bacteria, Escherichia coli, because these gram-negative bacteria usually cause septicemia in newborns. So these Enterobacteriaceae, all these are Klebsiella, all these will cause. So these will lead to meningitis. Hematogenous spread to the meninges will lead to meningitis in newborn. Group B Streptococcus is not common in our country, but in other countries abroad, European countries, Group B Streptococcus is also common cause. Listeria monocytogenes, Haemophilus influenza, coagulase negative Staphylococcus. Usually the spawns, coagulase negative Staphylococcus, we will call it as spawns, acquired in hospital acquired infection, and Streptococcus pneumonia common in community. If in neonates and infants less than 2 months, the commonest bacteria are Escherichia coli, Staphylococcus aureus, gram-negative bacteria, hospital flora, means hospital acquired infection, Listeria monocytogenes, group is Streptococcus. Okay, these are the common organisms from neonates to less than 2 months of age. From 2 months to 3 to 4 years, 3 to 5 years, usually community acquired organisms like Haemophilus influenza, Streptococcus pneumonia, also called as pneumococcus, Neisseria meningitidis, meningococci. So these are the organisms which are common in the 2 months to 3 to 5 years age group. Beyond 5 years, if you see beyond 5 years, the organisms are like almost like adult Streptococcus pneumonia. These are the subtypes 1, 3, 6, and 7. Neisseria meningitidis, these are the subtypes A, B, C. Haemophilus influenza. Post neonatal childhood bacterial meningitis. causative bacteria. If you see post neonatal 1 to 23 months, Streptococcus pneumonia, Neisseria meningitis, group B Streptococcus, Haemophilus influenza. 2 to 8 years of age, Neisseria meningitis, Streptococcus, same as previous. If you see. So the post neonatal period, the etiology slightly changes. So bacterial culture positivity, if you take in post neonatal period, childhood bacterial meningitis culture, blood bacterial culture positivity rate, Haemophilus influenza isolation rate is 40 to 70%. That is growth we can see in 40 to 70% of the cases. In case of Haemophilus influenza, Streptococcus pneumonia 30 to 40% we can see the positivity rate. Neisseria meningitis 10 to 20%. Streptococcus pyogenes less than 10%. Culture negative usually less than 20%. Culture negativity also will be there. Varies with age of the child. These isolation rates also varies with age of the child. What are the predisposing risk factors? Sinusitis, mastoiditis, otitis. Okay, sinusitis, mastoiditis, and otitis. Because these sinuses are and mastoid sinus and otitis ear, all these are close to brain, and there will be connections in the form of venous blood neurovascular bundles communicating with the sinuses also. So easily the infection can go to the meninges through the sinusitis, mastoiditis, and otitis ear infection, inner ear, middle ear. So spleen is an protective organ, lymphoid organ. Every one of you know. If there is asplenia or functional or anatomical absence or trauma or removal of spleen will lead to pneumococcal bacterial meningitis, because spleen is the organism which is graveyard for capsulated organisms. Haemophilus influenza will have a capsule. Pneumococcus or Streptococcus pneumonia will have a capsule. So these organisms, okay, these organisms will start invading once there is no spleen or functional absence of spleen. You already know that immunocompromised hosts like HIV or severe acute malnutrition in case of pediatrics are an important predisposing factors for this meningitis. The other causes are like neurosurgery. We will be performing surgery for some cyst in the brain or something else, and it can cause infection into the meninges. Head trauma also may have some fractures in the skull, and infection may go through it. Parameningeal infection means it's not directly the meninges, but somewhere close to the meninges. Parameningeal infection. Anatomical deficiency of cranium. So you know, calvarium absent means bone is absent in some cases in the newborn period. So there easily the organisms can invade if there is absence of bone. Spinal cord and meninges. In spinal cord, you already know spinal cord, what spina bifida and all these kind are open myelomeningocele. All these conditions you can, okay, you can know that easily the organisms can invade. So what are the risk factors in neonatal meningitis? So neonatal meningitis, maternal infections, that is during delivery, from maternal genital tract. So during delivery, some organisms like group B Streptococcus can also cause this meningitis. PROM, preterm premature PPRM, premature rupture of membranes or prolonged rupture of membranes. PROM is prolonged rupture of membranes, will lead to ascending infection from maternal genital tract into the womb, so that the baby will be infected within the mother's womb. If it is a severe type of infection, is chorioamnionitis, including placenta also will become inflamed and infected. If there is prolonged difficult delivery with frequent paravaginal examinations, so always We should reduce the number of pervaginal examinations. Unnecessary PV examinations are not indicated. So preterm babies, already preterm, immune system as well as their weight, everything is less and they cannot fight infection. So preterm babies are also more prone for this sepsis as well as meningitis. We already discussed neural tube defects like spina bifida occulta and pilonidal sinus. All this will lead to ascending infection into the spinal cord. So if you see the pathogenesis, inflammation of spinal roots, nerves and roots is called, and for this, due to this inflammation of spinal nerves and roots, there will be signs of meningeal irritation. Adhesive thickening of arachnoid in basal cisterns, exudates. If you see exudates underneath the basal cisterns, okay, adhesive thickening of arachnoid in basal cisterns will cause obstruction of these ducts, fibrosis and obstruction of aqueduct of Sylvius, foramen of Luschka or foramen of Megendi. All this will get obstructed and will lead to hydrocephalus. You already know that what is hydrocephalus. So if there is end arterial inflammation and small cortical venous thromboembolic episodes will lead to cerebral infarction, atrophy of that part of the brain tissue. Because end arterial inflammation is due to that infection. Neuronal membrane depolarization also will occur due to the cerebral infarction, leading to seizures, fits. Pathogenesis of acute bacterial meningitis, if you see, mostly hematogenous spread. Spread from local site of infections also can occur. From nasopharynx also it can gain entry. So entry of bacteria through blood-brain barrier leads to acute bacterial meningitis. Cellular reaction with outpouring of polymorphs and fibrin, release of cytokines, chemokines, and inflammatory mediators. Okay, anyhow, when bacteria enters into the crossing the blood-brain barrier, all these inflammatory markers and that fights polymorphs, release of cytokines, chemokines, inflammatory mediators will happen. Release of cell wall and membrane debris on cell death. Meningeal exudative formation, because pyogenic meningitis, one problem is there will be formation of exudates. Exudate will finally lead to obstruction of all this foramen of Luschka, Megendi, and lead to hydrocephalus and damage to the brain surrounding. Normal brain tissue also will get damaged. Vascular compromise, you already know vascular compromise will occur because of inflammation of the vessels, and there may be blood supply also hampered to certain parts of the brain, will lead to infarctions. Inflammatory cerebral edema, because there is infection obviously leads to vasculitis and inflammatory cerebral edema to that part of the brain. Increase intracranial tension and pressure. Coning effect means rise ICT, intracranial pressure ICP will lead to coning at this base of the skull and lead to compression of vital centers in the brainstem. That is respiratory and cardiorespiratory centers. Okay. So what are the signs and symptoms and signs of acute bacterial meningitis? Symptoms in case of infants and children usually have fever, irritability, excessive fussiness. Irritability is also very important, because even though the child is conscious, alertness is very important. Means previously how the baby is alert with his surroundings, and when baby is irritable, they will not mingle with the environment. They will be continuously crying or irritable. Excessive fussiness means they will not concentrate on anything and they will be irritable. Just if you just stimulate them, they will be crying. So all these things. Altered behavior. Previously the child used to play happily eat food and all these things. When there is change in behavior, that also should concentrate. A refusal of feeds. Child is and not eating, using feeds, and not eating well, and even drink water also input has reduced, then we should be very much conscious of these things. Lethargy means extreme weakness can occur, and anorexia, loss of appetite. Nausea means vomiting like sensation. And photophobia means there is whenever they see a light, they will have this fear of light into their eyes. That is called photophobia. Because of papilledema and all these things, they will have photophobia. Altered sensorium on sign. These are signs. The child will have altered sensorium. But if you examine, there will be bulging anterior fontanelle, headache. Child may complain of headache, convulsions, fits, seizures, nuchal rigidity. Opisthotonus means there is positioning of back and extreme extension because of paraspinal muscles going into spasm. Hypothermia and coma can occur. Okay. So what important historical information you will get? If you take past medical history, recent illness, chronic illness, head, facial trauma, past surgical history, shunt in the brain, cochlear implants for hearing loss, birth bar perinatal history, maternal sexually transmitted infections, chorioamnionitis, infection of all the membranes of womb, prolonged rupture of membranes, perinatal infection, immunization, full review of vaccines, including dates of pneumococcal and meningococcal vaccine is important. Medication in the past 6 months, NSAIDs, immunosuppressive agents, recent intravenous immunoglobulin, antibiotics. We should all take this past medication history. Exposure of recent contacts, child care, where the child is being cared, vectors including bites of mosquitoes, contact bats, tuberculosis exposure always should be examined. In the general physical examination, if you see, breathing, airway circulation is always important in any emergency, and we should look for whether they are adequately maintained or compromised. Compromise means we should be giving them advanced life support measures. Altered sensorium and severity in coma scale. Okay, we should always see GCS in children also. Vital parameters like temperature, pulse, blood pressure, respiratory rate, type of breathing, regularity of pulse and respiration, capillary filling time, and hydration status is all these are very important. You take skin mottling, color change of vascular compromise, purpura, infection, dermal sinus, and other stigmata of spina bifida occulta. Skin, if you see, mottling means libido reticularis will occur. Color change of vascular compromise, purpura due to infection. So this is the libido reticularis. Okay, cutis marmorata. Here all the face. So this is due to vascular compromise. These are all purpura, fulminant purpura in case of meningococcal septicemia, meningococcus. Okay, skin in acute bacterial meningitis complication. You see, these are purpuric spots. These are ecchymotic patches. Okay, they will be very sick and terminally ill. Poor kids. So examination of signs of meningeal irritation is very important. Meningismus. Meningismus is similar to meningitis sign. Meningismus means neck stiffness and rigidity, which is not due to infection. It is due to non-infectious causes. Okay, meningismus is we should be looking for local stiffness, neck stiffness, rigidity, Kernick's sign, Brudzinski's neck and leg sign, Brudzinski's crossed leg sign. All these things are very important. Neurological signs, higher mental functions, cranial nerve examination, motor coordination should be examined for. So, elicitation of meningeal signs. Brudzinski's contralateral reflex sign. Here, Brudzinski's sign is there, no? What is this? Child is lying down. In Brudzinski's sign, the neck only neck has been flexed. Then, what is the response we get? There is immediate flexion of at the hips and knee level, because here we are extending the meninges by flexing the neck. The pain, to reduce the pain, child will do flexion of hip and knees. Okay, this is Kernick's sign. Kernick's sign, what will happen? Will the child make the child lie flat and slowly, gradually lift one leg with making the first hip and knee at right angles to each other, and then gradually extend the knee without moving the hip. Then the child will wince with pain and he will again cry of pain and neck, flexes his neck also and so he will move up. Brudzinski's sign, if it is positive in the patient, if the patient hips and knees flex automatically, and the examiner flexes the patient neck while the patient is in supine position. Already I have told you, no? This is, what is this position? Can anyone say what is this position? CR.
Opisthotonus.
Yeah, this is opisthotonus. And one more thing, you can also say there is both extension of plantar flexion of this foot, and as well as here also there is flexion. Where we will get in which posture? Decorticate posture or decerebrate posture? All limbs extended. Which posture?
Corticate.
All limbs extended. All limbs extended, decerebrate. Upper limbs flexed, lower limbs extended is so many of you there. Please speak out, someone. Hello.
Yes, sir.
What is this? Decerebrate or decorticate?
Decerebrate.
This is decerebrate posture, correct. So investigations in acute bacterial meningitis. What investigations we will order? First of all, immediately after stabilization of the child, we should send some blood investigations immediately. First, complete blood count should be done. If there is no contraindications for lumbar puncture, get a CSF examination done. Microscopy to look for color of the fluid, CSF fluid, cells, and we should also measure through using a manometer, pressure manometer, the opening pressure. Okay, opening pressure means whenever you puncture the meninges and CSF is coming out, we should immediately monitor with a manometer. But opening pressure, if it is high, it indicates rise recipe. Biochemistry, glucose should be, usually in pyogenic meningitis, glucose will be very less, proteins will be very high. Gram staining, blood and CSF culture is also important. Both should be sent. Electrolytes, arterial blood case in case of severe cases, chest X-ray, very important to look for focus, whether it is hematogenous spread from a pneumonic focus or something due to streptococcus pneumoniae, we should get an chest X-ray. CT and MRI, CT bar MRI scans of brain if required. EEG stages are there. PCR, multiplex PCR to identify the antigens in the like streptococcus pneumoniae, haemophilus influenzae, whatever they are causing organisms, PCR may require. Contraindications for performing a lumbar puncture in children is if there is a rise in intracranial pressure by bulging AF and child is also very having headache, vomiting, we should avoid doing, because in during raised ICP if you do lumbar puncture there is always chances of uncal herniation and cones, cerebellar tonsillar herniation, then immediate death can occur. So always be careful. Whenever there is raised ICP, don't do lumbar puncture. We should always examine for papilledema, that is inflammation and edema of disc, optic disc. If the child is papilledema indicates raised ICP, chronically raised ICP, so you should stop performing lumbar puncture. An unstable child like shock, respiratory depression, low GCS, Glasgow Coma scale, infection in the local site in the spine, severe thrombocytopenia. Okay, less than 50,000 don't perform. Usually previously less than 1 lakh we used to stop doing, but now less than 50,000 we should not do at all. DIC. What CSF findings we will get in CNS infections? If you take infection, acute bacterial meningitis, TB meningitis, viral meningitis, aseptic meningitis, cryptococcal meningitis, and normal. If you see, normal pressure is 80 to 200, okay, millimeters of Hg. Here, WBC for microliter is less than 5 lymphocytes, glucose 50 to 75, protein 15 to 40. These are the normal values. If you see in acute bacterial meningitis, the highest rise in WBC is in bacterial meningitis. 1,100 to 5,000, more than 50% are polymorpho nuclear leukocytes. Glucose will obviously come down, less than 40. Protein will be high, elevated, more than 100. In TB meningitis, the pressure is almost equal to acute bacterial meningitis. Lymphocyte predominant, lymphocyte, not polymorphonuclear lymphocytes. Lymphocyte predominant, 100 to 500 cells. It may be low, glucose may be low, elevated protein will be there. Viral meningitis, lymphocyte predominance, less in normal or less in mumps, normal or slight rise. Aseptic meningitis, same lymphocytic predominant, normal in glucose is normal in aseptic meningitis. Cryptococcal meningitis, less lymphocytes but low glucose and protein elevation. Okay, this is gram staining you have performed in your first year. So methyl violet followed by iodine staining, alcohol wash decolorization and diluted carbol fusion. Gram staining procedure, follow the flow. On a rack, flood with filtered crystalline violet, methyl violet 10 seconds, wait. Wash briefly in water to remove excess crystal violet. Flood with gram stain iodine, grams iodine 10 seconds. Wash briefly in water, do not let the section dry out. Decolorize with acetone or alcohol. Wash immediately in tap water. Counter stain with saffron. Okay. You can see non-motile gram-negative bacteria, Coccobacillary, facultative anaerobic bacterium, and its oxidase and catalase positive. Okay, here this in chains. Here diplococci, pneumococci. Okay, diplococci. This is the agar plate, Haemophilus influenza on the agar plate. Okay. What other investigations you can perform is to detect a specific bacterial antigen, latex particle agglutination of CSF, cerebrospinal fluid. H. influenza, Streptococcus pneumoniae, Neisseria meningitis, and E. coli. Counter immune counter current immune electrophoresis is also one more. And smears from purpuric spots, gram stainings. Rarely you can identify Neisseria meningitis and Streptococcus pneumoniae. DNA sequencing is done in advanced centers, not available. Bacterial identification. These are the other investigations. Acute bacterial meningitis. What are the differential diagnoses for it? Partially treated meningitis, viral encephalitis, cerebral malaria, tuberculous meningitis, enteric encephalopathy, leptospirosis, metabolic or toxic encephalopathies, dengue, hemorrhagic. See, so many differential diagnoses are there. Whenever someone asks you what are the differential diagnoses of by bacterial meningitis, you should always say partially treated meningitis, viral encephalitis, cerebral malaria, and TB meningitis. At least these four you should be able to say. And next, enteric encephalopathy you can say. Next, later these can be said. Okay. What are the complications? Acute and chronic complications. What acute complications you can expect? Increase intracranial pressure. Already we have seen increase intracranial pressure and coning pressure effects. Immediate coning, cerebellar tonsil herniation, and death. Subdural effusion. Subdural. Without the dura, there can be effusion and compressive effect on brain. Septicemia and septic shock. Seizures. Because compressive effect of these effusions or cerebral infarcts in case of meningitis can lead to seizure. Syndrome of inappropriate ADH, if hypothalamus is affected, SIADH can occur. Acute hydrocephalus can occur due to blockage of these exudates, blockading the what? Aqueduct of Sylvius, Rushka, Magendie, if you block, then hydrocephalus. Cranial nerve palsy. Palsy, sixth nerve usually occurs. Third nerve also can occur. DIC, disseminated drift. There is severe septicemia, DIC can occur. Purpura fulminans can occur in case of Neisseria meningitis. See this kid post meningitis, there is acute. What are those two? Dilated lateral ventricles. See how it is. Surrounding brain tissue is compressed. Head size increasing. This is meningitis. Poor kid. Here are subdural effusions. These are the dilated horns, frontal horn, third ventricles, occipital horns, and VP shunt. Ventriculoperitoneal shunt is here. Shunt. This is a CT scan of brain. And there is cerebral edema also in these pictures. What are other complications? Commoner after bacterial meningitis than other viral meningitis. Sensory neural hearing loss, partial or total, is a complication of meningitis because this eighth nerve is extremely sensitive to the effect of this meningitis. Exudates will damage the eighth nerve. Seizures and epilepsy, lifelong it can occur because some part of the brain may go into atrophy. That will be acting as nidus for this seizure. Focus. Cognitive problem, because brain is damaged, how the child will concentrate on anything. Memory and concentration will be gone. Learning disabilities and behavioral problems can occur. Motor problems like incoordination, balance can occur. Speech may be gone completely or slurring speech can occur. Visual disturbances. If third nerve and optic nerve are affected, visual disturbances. Cerebral palsy. Complete neuro developmentally child will become static, will not progress further development. The greatest risk for hearing loss in case of males, nuchal rigidity. If there is nuchal rigidity, there is greatest risk of hearing loss. Raised ICP, low CSF glucose levels, Streptococcus pneumonia infection, abnormal CT scan findings. So overall mortality for bacterial meningitis is usually 5 to 10%. In neonates, 15 to 20%. See, the lower, very young the age, mortality is high. Older child, 3 to 10%. Bacteria wise, if you see common organisms, Streptococcus pneumonia, 26.3 to 30% mortality. Haemophilus influenza type B, 7.7 to 10.3%. Meningitis, Neisseria meningitis, 5 to 10.3%. Neurologic sequelae, 30%. So always be careful. Post meningitis, there can be neurological sequelae in the form of palsy, seizures, neurodevelopmental delay, all these things. Poor prognostic factors. A child affected with meningitis, what are the other poor prognostic factors are? Age. Neonates and preterms, organisms like pneumococci, H. influenza, meningococci are life-threatening. Gram-negative organisms, Salmonella, Enterobacteriaceae, DIC, endotoxic shock, neural tube anomalies, immunosuppressive individuals. These are the poor prognostic factors. For bilateral hearing loss, what are the poor prognostic factors? Previously, we already said same things. Prognosis: 1 in 4 survivors had serious and disabling sequelae, functionally important behavioral disorder, or neuropsychiatric problems, auditory, hearing problems that impaired their school performance. So what you should do? Suspected bacterial meningitis based upon history, rapid assessment, airway, breathing, circulation, and levels of consciousness. Initiate cardiorespiratory monitoring, venous access, means IV cannula, immediate hemodynamic support, obtain basic laboratory evaluation like electrolytes. For SIDs, reduced sodium should be corrected immediately. Blood urine nitrogen creatinine, CBC with differential count, DIC evaluation, petechiae porphyria, blood culture. Assess for contraindications to lumbar puncture. Yes, no. If there is no contraindication, perform lumbar puncture. If there is contraindication, yes. What are the contraindications? Increased intracranial pressure, coagulopathy, hemodynamic instability. Okay, administer dexamethasone to reduce inflammation, 0.15 milligram per kg, and begin empirical antibiotic therapy with which covers both gram-positive and gram-negative organisms. Vancomycin gram-positive, cefotaxime or ceftriaxone for gram-negative. Admit into NICU or PICU, depending upon the age of the child. Administer dexamethasone, already we have done. Admitted to ICU, increased intracranial pressure, corrected. We have to correct raised ICP. Coagulopathy, we have to correct by platelet transfusion or FFP transfusions. Hemodynamic instability should be corrected and perform lumbar puncture. Continued assessment for SIDH and other complications of meningitis. Empiric antibiotic treatment in childhood acute bacterial meningitis. So what empirical? Because we cannot always wait for all this investigation. We can take investigation. We have to start something on antibiotic because we cannot wait for the reports to come on. So neonates less than 1 month, risk group. Common organisms are group B or group D Streptococcus, group gram-negative rods E. coli, Listeria monocytosis. For that coverage, ampicillin on cefotaxime. Children 3 months to 7 years, Haemophilus influenza, Streptococcus pneumonia, Neisseria meningitis, ceftriaxone. Young adults, Streptococcus pneumonia, Neisseria meningitis, Vancomycin, ceftriaxone. Unknown. Infant age less than 1 month, children over 1 month of age, and adults. Ampicillin, ceftriaxone, gentamicin, ampicillin, ceftriaxone, vancomycin. Gram positive, ceftriaxone, vancomycin, ampicillin. Gram negative, ceftriaxone, gentamicin. Hemophilus influenza type is ceftriaxone. Meningococci, penicillin G plus ceftriaxone. So we are using ceftriaxone left and right. After some days, ceftriaxone resistance will occur and these organs will not die. Streptococci, vanco, nafcillin, listeria, ampicillin, gentamicin, trimethoprim, sulfamethoxazole. Enteric gram negative bacteria, ceftriaxone, gentamicin. Pseudomonas, ceftriaxone, cefepime. Staphylococci, vancomycin, nafcillin. Treatment of complications. If there is fits, seizures, convulsions, diazepam. Now no one is using diazepam. Lorazepam is using. Following which we have to continuously use some anti-epileptic medication for few years. Cerebral edema, mannitol, to reduce the cerebral edema and its complications. IV dexamethasone to reduce inflammation and inflammatory edema. Drainage of subdural empyema. Surgical management of hydrocephalus. VP shunt, ventriculoperitoneal shunting. Supportive treatment, correction of fluid and electrolyte balance, control and maintenance of normal body temperature, control of convulsions, anticonvulsive drugs, control of raised ICP, control of cerebral edema, care of comatose, unconscious, shell, skin, eyes, bladder, and bowel and bladder, lungs. We may have to intubate also. Protocol-based management of septic shock with fluids, electrolytes, and inotropics. Management of disseminated intravascular coagulation. Nutritional support. Always important, nutritional support. Monitoring of head circumference per hydrocephalus. Vital parameters, intracranial tension, report response to drugs. Treatment of complications like hydrocephalus, subdural. So always it is important to know differential diagnosis as well as complications of acute bacterial meningitis. Okay. Immunization to prevention is also very important. So how do we prevent? We will give routine immunization with available vaccines against Haemophilus influenza, Hib vaccine, pneumococcus, pneumococcal vaccine, meningococcus, meningococcal vaccine for high-risk children. Vaccination before traveling to endemic areas is also important. Prevention of acute bacterial meningitis. Antibiotic chemoprophylaxis with antibiotics is also important. Traveling to endemic areas. Haemophilus influenza type A, rifampicin 20 mg per kg per day for 4 days. Sriram meningitis, rifampicin 20 mg per kg per day or 600 mg oral for 2 days in older children. Ceftriaxone single dose. Ciprofloxacin single dose. Okay. Thank you. Am I audible?
Yes, sir.
Please give your attendance in the chat box. Okay. Okay. CR.
Yes, sir.
Yeah. Please give your attendance in the chat box. Thank you.